Compartment syndrome is one of those NCLEX topics students miss because they memorize the signs, but they miss the emergency. This is not regular pain after an injury. This is pressure building inside a muscle compartment, and that pressure can cut off blood flow. Compartment syndrome happens when pressure rises inside one or more muscle compartments. That pressure can come from inside the tissue, like bleeding or swelling, or from outside the tissue, like a tight cast or dressing. As the pressure increases, blood flow drops. If this continues, the nerves and muscles can lose oxygen and damage can become permanent. This is why NCLEX treats compartment syndrome as urgent. Neurovascular damage can become irreversible if treatment is delayed, especially within the first several hours after symptoms begin. If the pressure is not relieved, the limb can lose function. Severe cases may require a fasciotomy to relieve pressure and restore tissue perfusion. So, what should you expect to see? The major finding is unrelenting pain that is out of proportion to the injury. The pain may not improve with prescribed pain medication. Another classic finding is pain with passive movement. The client may also report numbness or tingling. The extremity may look pale, cool, dusky, swollen, or tight. You may notice decreased pulse strength. Here is the NCLEX trap. Do not wait for the pulse to disappear. Pulselessness is a late sign. Pain out of proportion, pain with passive movement, numbness, tingling, and delayed capillary refill are enough to take this seriously. By the time the pulse is absent, tissue damage may already be severe. Now let's prioritize it. The first nursing priority is neurovascular assessment. Check pain, sensation, movement, pulses, skin color, temperature, and capillary refill. Compare both extremities when possible. The goal is to catch poor perfusion before permanent damage occurs. Nursing actions focus on fast recognition and preventing more damage. Report signs of compartment syndrome immediately. Position the extremity as prescribed and avoid anything that worsens perfusion. If a cast or dressing is too tight, the provider may prescribe loosening the dressing or bivalving the cast. If symptoms are severe, the client may need a fasciotomy to relieve pressure. For patient teaching, tell the client to report severe pain, pain that gets worse, numbness, tingling, tightness, pale skin, cool skin, or trouble moving fingers or toes. If the client has a cast, teach them not to insert objects inside the cast because that can injure the skin. When you see compartment syndrome on NCLEX, ask yourself, is this expected pain or is perfusion affected? Is this an early warning sign or a late sign? Does the nurse need to keep watching or act now? With compartment syndrome, worsening pain plus neurovascular changes means act now. Here is the summary. Compartment syndrome means pressure is cutting off perfusion. Remember pain out of proportion, pain with passive movement, paresthesia, and poor circulation. The priority is neurovascular assessment, fast reporting, and preparing for treatment to relieve pressure. Nursing students, stay focused, think safety, and pass the NCLEX. This is the kind of NCLEX question that gets easier once you stop staring at the drug names and look at the interaction. Let's work through this NCLEX-style question together. A patient diagnosed with hypothyroidism is prescribed levothyroxine. During medication reconciliation, the nurse notes that the patient is also taking warfarin. Which adjustment should the nurse anticipate discussing with the provider? Option 1. Lower the levothyroxine dose. Option 2. Increase the levothyroxine dose. Option 3. Lower the warfarin dose. Option 4. Increase the warfarin dose. Now let's break it down. The key is the interaction between levothyroxine and warfarin. Levothyroxine can increase the effect of warfarin. In simple terms, once thyroid hormone is replaced, the patient can become more sensitive to warfarin. That means the risk of bleeding goes up. So if warfarin works more strongly, the provider may need to decrease the warfarin dose. That makes option 3 the correct answer. Now let's quickly eliminate the others. Option 1, lower the levothyroxine dose, is incorrect because the issue here is not that levothyroxine itself needs to be reduced. The problem is that it can make warfarin work more strongly. Option 2, raise the levothyroxine dose, is incorrect because there is nothing in the question showing the thyroid medication needs to be increased. Again, the focus is the interaction with warfarin. Option 4, raise the warfarin dose, is incorrect because that would increase the bleeding risk even more, and that goes in the wrong direction. So here's the test-taking step. When NCLEX gives you two drugs together, ask yourself, does one make the other stronger or weaker? In this case, levothyroxine makes warfarin stronger, so the safer change is to lower the warfarin dose. That is the logic. As always, nursing students, stay focused, think safety, and pass the NCLEX. If myasthenia gravis and multiple sclerosis still feel too similar, let's make it simple. Both can cause weakness, but they do not attack the same part of the nervous system. Myasthenia gravis affects the muscle receptor. Multiple sclerosis affects the myelin sheath, which is the covering around the nerves. So do not memorize them as both are weakness. Instead, ask, where is the problem? In myasthenia gravis, the immune system attacks the acetylcholine receptors. Acetylcholine helps the nerve tell the muscle to move. So the nerve sends the message, but the muscle does not receive the message well. That is why the hallmark sign is muscle weakness that gets worse with activity and improves with rest. The patient may feel stronger earlier in the day, but after talking, chewing, walking, or moving, the muscles become weaker. For NCLEX, think myasthenia gravis when you see drooping eyelids, double vision, facial weakness, trouble chewing, trouble swallowing, slurred speech, or shortness of breath. The big safety concern is swallowing and breathing. If the muscles used for swallowing are weak, the patient is at risk for aspiration. If the respiratory muscles become weak, the patient can develop respiratory distress. So nursing priorities include airway, aspiration precautions, respiratory assessment, and giving medications on time. Now let's compare that with multiple sclerosis. In MS, the immune system damages the myelin sheath. Think of the myelin sheath like the coating around an electrical wire. When that coating is damaged, nerve signals slow down or do not travel correctly. That is why MS symptoms can vary from patient to patient. The symptoms depend on which nerves are affected. For NCLEX, think multiple sclerosis when you see numbness, tingling, weakness, poor coordination, tremors, dizziness, or vision changes. The patient may have blurry vision, double vision, or nystagmus. MS can also affect bowel and bladder function, so watch for urinary retention, incontinence, constipation, or diarrhea. Nursing priorities include fall prevention, energy conservation, bowel and bladder support, and avoiding triggers like heat, infection, stress, and overexertion. Here is the quick shortcut. Myasthenia gravis means the muscles get tired because the receptor is the problem. Multiple sclerosis means the nerve signals get disrupted because the myelin sheath is damaged. So if the question gives you weakness that gets worse with use and improves with rest, think myasthenia gravis. If the question gives you numbness, tingling, vision changes, poor coordination, and bowel or bladder problems, think multiple sclerosis. Save this video and share this with your classmates.